of the Minister of Health with the public at large. This is our first event of this type. In the past, we had no this public process of the full-fledged public policy process. We never used to have this in Ukraine. The last week in the Verkhovna Rada, MPs had established the caucus, which is called a full-fledged policy cycle, which comprises MPs from all factions, and this way they implement recommendations produced by the European Parliament group under leadership of Pat Cox. And now, actually, we have this today's consultation, which is part of this full-fledged policy cycle. And actually, this is to explain why this or that draft law is submitted to the parliament and passed. Quite often, public tends to criticize the minister, including the Minister of Health, blaming her that she is doing something which is not known to the broad public instead of submission of the draft law to the parliament. But before submitting the draft law to the parliament, we have to discuss it with the broad public. So the policy agenda comprises three stages: vision of the future after reforming, obstacles to the reforming, and how the reforming should be implemented. So when the stakeholders are identified, then the consultations should take place, and we should predict social risks. We should mobilize the interested parties, and the white book should be compiled. First, green paper should be compiled, and later on the ground. So, green book, the white book, should be compiled. In this project, we work with the Center UA Center, with the Chesna platform, etc. Good afternoon, dear colleagues. We are witnessing the appearance of the right approach to policy agenda formation for the first time in Ukraine. Last week, we had a discussion about the available medicines in Ukraine. Then later, I switched on news, on TV, and saw the Prime Minister speaking actually in the same words which we said here in course of our public consultations. And I'm very much inspired when I see... We are very much inspired when I see that several ministers try to follow this full-fledged policy process, and how this is implemented into the real steps. I'm happy. At the same time, implementation of the reforms designed at the central level, implementation of those reforms at the local level. Of course, it may cause some concerns, but nevertheless, I hope that we have all the chances that in Ukraine, the reforms into which the society is involved will be understood by the society correctly, and that they will be implemented in right way. I think that if we have these public discussions, we set right diagnosis to the problems, and finally we will be able to find right solutions to these problems. Ms. Ulana Suprun, thank you for this opportunity to speak. We have our third consultation in the public health area. We had already discussed the changes to the healthcare healthcare system in general. We have submitted this new concept to the Cabinet of Ministers, to the Central Executive bodies. We have discussed and developed the concept of the medical insurance. We have submitted also the document about medical divisions, medical counties or medical administrative units in Ukraine. And yesterday, we submitted the concept about reference prices and reimbursement of money spent for medicines. Today we have the second step on this way. We are discussing the emergency medicines, and we used to explain that family medicine and emergency medicine are the primary level of our healthcare system. And we discussed how the system should be reformed and how funding of this system should be reformed. We also explained the clinical protocols, how they will be developed and implemented to the family medicine. Today we are discussing emergency medicine. We have our emergency medicine doctors from Ukraine, paramedicals from Czech Republic and from the USA. We have our partner, Dr. Blake Vandelan, which deals with these issues in the United States for almost 20 years, and my colleague who has been dealing with this area of medicine for almost 17 years. So we would like to discuss with you how we see the emergency medicine system operation in Ukraine. In order to prevent a situation when there would be two extremes. Some people thinking that we have nothing, and some people thinking that we should preserve what we had in the past. I won't speak much. I would like to give the floor to Oleksandr Linchevskyi, who's a surgeon, an experienced surgeon in the municipal hospital number 17. Now he is deputy minister. I would like to ask Oleksandr to explain the changes which we suggest to have in pre-hospital treatment of patients. Good evening. First of all, today here in this nice room of the Ukrainian Crisis Media Center, we should remember now, at this very moment, all our colleagues, our medical workers remain in the hotspots in Avdiivka, Stanitsa Luhanska, Mariupol, etc. This is the most reliable unit of the medical service, beginning with surgeons and doctors up to car drivers who are ready to provide assistance to people, to help to rescue people. We are very much dependent on that invisible medical staff, which is on duty and always ready to help us. So what do we have to do? We have done something already, but what we need to do more? I do not think that I should repeat once again the issues, the problem issues in emergency service delivery which we have in Ukraine today. Let us step aside and try to look at the system from outside. Let us imagine that there is some emergency, some unexpected pain, some trauma, and before arrival of the emergency service car, what we can do in this period of time? How quickly does the emergency car, the ambulance, arrive? How who will come? Where it would go? What will happen to this patient in course of transportation? Who will meet this patient at in the hospital, or where the ambulance car brings his or her? What those doctors will have in their disposal meeting the new patient. So we need to ask all these questions and to answer them to understand what we wish to do. Do we have time? Can we show the video fragment? Let us watch the video. The first fragment. Sorry for the quality, but this is the internet video. There is the road accident or some emergency case, some accident. The cars continue to move. They have put this sign of the accident on the road. You see there's three men who stand around doing nothing. They should, in their driver's school, they had to be trained for emergency situations, and also they had to have medical kits in their cars, and you see that all the vehicles passing by. I think that professional drivers driving buses, trolley buses, etc., they might know what to do in all these situations. And by the way, those first minutes after the accident may become the most important for the later period. Now you see the military paramedicals who accidentally were passing by. You see two persons with maybe medical education who still try to find something in their bag, whether that bag is properly equipped. What do they have in that bag? Or whether they are able to deliver real aid to this patient. And actually, you may notice that still nothing is happening. They are not giving any assistance. Look, again, paramedical came, he has watched how bad it is. 1 second, 2 seconds, 3 seconds, 5, 6, 10 seconds, etc. Look how much time does it take. Whether during all this time anybody is given any assistance to this patient. You have the ambulance car, you have emergency medical crew, a lot of medical workers, etc. Okay, finally they took them and hopefully started to do something, but they will simply took him to the car, and we do not know what will happen. What will happen in that car, we do not know. Later, we will find this patient in the hospital. So this simply shows that there is a huge space for improvement. Of course, we may say this is pre-hospital services. Let us build a good hospital instead. But statistic of death and statistics of treatment proves that we should not ignore this stage of medical services. Quite often the patients do not survive during the way to hospital, and real lives are to be rescued in this very short period of time. Now let us try to stay optimistic, to preserve our optimism, and try to understand what happened in this case, which we saw on the video. Probably somebody called to the rescue service, and how did they responded? Who, where the vehicle was, which was at the moment the dispatcher sent it to the site of the accident. We cannot be sure that the most close vehicle was directed to the site. So let us try to analyze how do we act in case of accident. The emergency medicine should be based on maximum informal approach to all this stuff, which means that there should be high quality drivers, very well trained drivers. In the United States, the police and firemen come to the place of accident even earlier than medical staff. And these are those people on whose activities the life depends. Let us assume that a passenger falls on the railway in metro, in university station, university metro station. The hospital is in 100 meters only, but how much time will it take for the crew of medical staff to run to or to drive to the metro station, to go down to the subway and to deliver first aid? So the first step is to the quality of drivers, and now we are changing curricula which we have for the drivers. We have developed special training course. The first to come to the emergency site or to the accident site for police officers. We believe that all the policemen at the state level should be trained this course. The same is true for the firemen and for the emergency services workers, to the National Guards officers, etc. So the ambulance car should arrive via the most optimal route. The most close car should be sent. In many regions, we already has created this map of the routes and the system which enables the operator to send the most close car. Please remember that we are fighting for each minute. We need to have a dispatcher system, the operator who will control where each ambulance car stays at each moment and able to send the most close. We have requested for additional funding for this dispatcher service, and we will try to implement this better approach. In some regional centers of Ukraine, we found out that oblast region administrations invest local money into this service, not waiting for our central requests. So the call about an accident comes to the dispatcher. We analyzed the statistics of the calls. We have 9 million of them per year, but only 2 million of them results in a real call for the ambulance car and hospitalization of the patient. But 7 million of other calls does not result in hospitalization. Quite often people call to 1 103 telephone medical service in case of raised temperature, because they do not know the telephones of their family doctors. And quite often emergency cars attend patients responding to such a negligible from emergency medicine point of view problems. We need to have a telephone which can provide some advisory consultancy for people, allowing emergency dispatcher to work with the real calls which require real needs. When we look at Kiev and Toronto, they are rather similar in terms of resident numbers, in terms of the size, in terms of population. In Toronto, they have 3 times more emergency service posts than in Kiev. We cannot cut down the number of such emergency posts, emergency locations in Kiev. We know that we have a lot of traffic jams, and we have to comply with high standards. If we wish to, that emergency car comes within not 12 minutes, but within 10 or even 4 minutes, we should not cut down the number of these units. Some patients simply won't survive. In order to have this, we need good dispatcher point, and we need to have a network of emergency posts where the cars are waiting and are able to arrive. Now about the cars. Of course, those posts need to have the emergency cars. The emergency cars should be properly equipped. We already issued the new lists of equipment, new lists of medicines, which should be available in each emergency car. Then the personnel inside the car, whether that medical staff which is in the car, whether they are properly trained to deliver help, to deliver aid. You saw that video when 2 medical workers arrived and they stood around doing nothing. Very soon we are ready to start retraining of our staff, of our personnel. The blood current is similar in Ukraine and in Canada, and that's why we should keep in mind the best international standards, trying to deliver aid to people. So training should be of the same quality, without no compromise, similar to developed countries. We have also medical science at our disposal, and our aid protocols should be based on the new achievements, new research achievements. We definitely will review them and approve new protocols, and maybe the last important thing is the new occupation, new professional, paramedical. This is a person having bachelor degree in medicine, which is specifically trained to deliver paramedical assistance at the emergency service. Now we are creating changes to the classifier of specialities, to the list of specialities. That is, we will have professionals who will be trained from the very beginning, who will be trained for this job from the very, very beginning. For us, it goes without saying that paramedical crews, paramedical teams should work more rapidly, and the results of their work should be better. The motivation of paramedicals everywhere in the world is also much better. So in overall result, the teams of paramedicals which are properly trained, which are properly motivated, which are properly prepared and equipped, they work much better. So we will introduce the changes to the list of specialties, professional list of occupations, and we will have this in our legislation. I would like to ask Blake to describe the organization of emergency services in hospitals. We plan to devote our special attention to this issue, but after I will describe describe this later. But now I would like to ask Blake to say a couple of words how it should work, and I will to make more optimistic finish to my intervention. I would ask to show the police video. This is in the video made in the United States. Mom with the baby. This is a policeman. It's not a paramedical. Yeah, it's not the best video. He is carrying out reanimation actions. He involves a father of this child. He knows what to do, not what to do. He takes something. He is equipped. He takes a medical kit. He knows how to apply this. Look at this. There are parents nearby, and there is a policeman. This is here. It's only at a distance of 8-9 hours from us. And look at the same characters. These are the same parents and the same policeman. And I think this could be achieved, but in order to implement changes, we should start doing today. That is actually what we try to implement. Thank you very much. Now, I would like to ask Dr. Blake Vandelan, who is a surgeon, the emergency situations specialist, who spent many years in the army service. He will describe how the emergency units are organized, how they worked, and how doctors the emergency doctors are trained and describe the occupation, which is called who is the trauma surgeon, not orthopedic surgeon, but trauma surgeon. Blake will speak English. If you wish to listen to Ukrainian translation, please take your headphones at the end of the room.
Thank you for the opportunity to be a part of this important discussion. So people die in systems that aren't set to act. If you're not sure of what your role is, if you're not sure of where your equipment is, if you're not sure of how to treat things appropriately, then people die. So specialization in understanding allows individuals to move in terms of both efficiency and efficacy. And this has been a constant development that's happened, at least in the States, throughout the greater part of the last century and continues into this century. I will say that that's not been easy. It's not been easy because there's nothing more difficult in its introduction or more uncertain in its outcome than the introduction of a new order. Why is that? It's because people have emotional, financial, intellectual, and social interests in investments in previous systems, and they don't want things to change. They like things the way they are, and they want to continue in that manner. And change to these folks can be a sign of concern and fear that their positions will be uprooted. To combat this ideology, we've decided that the dignity of the individual supersedes the dignity of the political systems or other oppositions that we have. But that doesn't mean these aren't formidable to change. The real change that's allowed to happen is when people survive and they see people getting better on a whole host of levels. Plus, we're able to treat these people and return them to the jobs, into home lives, or to retrain them back into society so that they can once again feel themselves as contributing members of society. If they're not able to be contributing members of society, then we have systems set up so that they can live out their lives in a manner that's consistent and dignified with human existence. So, to say that, what is specialized in what's happened in the United States over the, I would say, past 75 years is a recognition of emergency medicine and trauma surgery as its own unique fields. Originally, emergency rooms could have been staffed by podiatrists, ophthalmologists, radiologists, psychiatrists, and a whole host of people that weren't specialized in the area of emergency medicine. Now we have people who specifically go through training immediately following their medical education, and they advance themselves into their training specifically for emergency medicine. There are people who train then in general surgery and then go on to have additional specialization and training in trauma surgery. When the activations happen in the hospital, and the pre-hospital delivery system delivers a patient to the trauma system, the trauma system as a whole is aware of who that patient is and where that patient came from. That patient is directed to a facility based on, one, the urgency of the patient, and two, the capabilities of the system and the individual institutions. In order to arrive at this, we have multiple algorithms, and we have consolidation and organization of all types of operations: political, social, police, medical, and media. So, when the patient arrives, people know exactly where they're supposed to be, what their roles are, and what they're supposed to do. This allows us to determine accurately, quickly what's needed for that patient, and then to move that patient into therapeutic scenarios that result in the most efficacious outcome. So this relieves anxiety amongst people as well, because people know in the society that if they do something, that they'll have accurate and efficient care. It's not perfect, and there are many people who have different levels of talent. And there are many institutions that are challenged by location. As an example, I can share with you that the average time for an EMS transport, that's pre-hospital transport, in the US is under 5 minutes. That's a distorted data. It's a distorted data because it doesn't take into account the problems that we have, which the Ukraine has, which is large rural areas. So most of the transports that occur actually occur within the city. And there's hospitals abound within the cities and the developed areas. So those patients are able to get rapidly to the hospital from a very structured and well-trained EMS system. That means emergency medical service, if I'm using abbreviations. We have other systems that allow evacuation of those patients from rural areas. And this allows them a great deal of comfort knowing that they can have access to systems as well. So access, efficacy, and efficiency, as we've developed specialties and we've learned to deal with these things on a recurrent basis, our costs have been driven down. And along with that, our outcomes have been driven up. And we take pride in that, and we have rallying cries that focus around the outcome of the patient that allow us individuals to determine new things and new ways of doing things.
Mr. Blake, I'm sorry, please speak a bit slower.
I'm sorry. The current system allows further specialization. What is developing within hospitals in the US is based on a different analogy and a different focus of how a hospital works. Previously, people viewed hospitals as having silos or columns of activities within a larger system. In the management protocol or idea was to drive down costs within those individual silos in order to decrease costs overall. What the realization now is that I may have to spend X dollars more in one silo in order to get 2 times X reduction or greater in another silo. And this has developed ideas about managing health in emergency medical systems, resulting in an integration of trauma surgeons, emergency medicine physicians, and other specialties within that, which I mean trauma surgeons, orthopedic surgeons who have gone on to train in trauma, respiratory therapists that have taken an interest in trauma, EMS who have gone on to have additional training in trauma. And what has this allowed? This has allowed a further development, which has been acute care surgery. So trauma surgeons are now being trained with additional training after general surgery that results in them being able to handle all emergency surgeries in addition to trauma and then caring for those patients in the ICU. This mandates and requires intimate relationship with emergency medicine physicians who train specifically on dealing with the medical emergencies in their broader sense, including the non-surgical emergencies that present to the emergency room. So this has developed an integrated system that has really promoted efficacy in those environments and has caused for greater efficiency across all fields, as people no longer have to spend time dealing in areas which they're not specialized. For EMS?
Training for emergency medical physicians.
Emergency medical education, at least in the United States. So, physicians are first trained as they must graduate college, and there's a 4-year degree that's required for that. There used to be great specificity in that they wanted people who were biology majors or physical scientists or engineers. That's been discharged, and now we have people from all walks and all specialties in undergraduate training, including art history, psychology, archaeology. There are basic requirements that need to be met, and you have to meet those with a certain caliber. Testing and competition then results in admission to a 4-year medical school. There are 2 groups of physicians in the US. One are osteopathic physicians, and the other are allopathic physicians. Allopathic physicians end up with the degree MD, which is what I went to, and osteopathic physicians end up with the degree DO. Originally, there was a bit of separation between these two, but as we go along, they're continuing to be molded together. These differences were based on different philosophies that arose in the 1800s about how to treat patients. Following completion of your 4-year medical school training, a graduate then elects to go on to further training. In most states in the US, in order to be licensed as a physician, you require at least 1 year of additional training, which is called an internship. There is testing that is required there, and there's testing that is required in order to graduate medical school. At completion of 1 year or 2 years in some states, you then continue into what's called the residency. Some of these are just united, and it's called a residency overall. Emergency medical physicians are either involved in a total of 3 years or 4 years. That includes 1 year of internship and then 2 or 3 additional years of emergency medicine training. At completion of that, they're then challenged by an emergency medicine board, which requires both a written test and an oral test. The oral test is considered a test of safety. The written test is considered a test of fund of knowledge, and there are requirements for those. Following that, they can and then go on to additional training, which are called fellowships. Fellowships in emergency medicine include toxicology, ultrasound, radiology, and other specialties that descend from there to coordinate with the radiologist. This is not to say that they're radiologists overall, but they can have imaging specialties within that area. Surgeons. Surgeons have the same medical school requirements, 4 years, and they have the same undergraduate requirements. So after completing medical school and passing their tests, they also, like all physicians, have an either 1 or 2 year requirement, depending on what state they live in, before they can be licensed. General surgery training is now 5 years. At the completion of general surgery, a general surgeon can then elect to continue on with additional training in trauma. Trauma training has now developed into an additional 2 years, which is now called acute care surgery. These programs require you to learn how to treat emergency general surgery procedures as well as trauma surgery procedures, and include an entire year of critical care training. At the end of these 2 years, you can challenge the board and receive classification as a critical care intensivist. There is a rising wave of influence that is also moving towards a board certification, which is what those tests result in. But it will be called acute care surgery / trauma surgery. That has been the development along those lines. Orthopedists can go on and have additional training in trauma orthopedics as well. Their residency is also 5 years, including the 1 or 2 years of internship, and then they go on to an additional 1 or 2 years of specialty training in orthopedic surgery, emergency orthopedic surgery. I will say that trauma surgery in the U.S. is not popular. It's not popular because we don't have a fancy lifestyle. We don't get invited to the yacht club, and we don't get to hang out with the plastic surgeons and the really cool people who get to be on television. So we stay up at night, usually all the time. We have to operate a lot. We're in the hospital a lot. We don't get paid as much as the other groups, and we're basically adrenaline junkies. So we're interested in treating really difficult things. We don't have time to plan operations. So this is not the hip thing of Beverly Hills 90210. So there's a challenge because there's a marked deficiency of both emergency medicine physicians and trauma surgeons in the U.S. Although that is gaining, those problems are being solved. Thank you.
Дякую. Я хотіла розповісти.
Thank you very much. I wish to tell you why do we have Dr. Blake today among us. Why today he described all that because of new specialties, new occupations to be introduced in Ukraine. 2 years ago, we launched the program Life Supporting Course and Course of Trauma, and this was started by Patriot Defense NGO. This was a 6-day course training medical workers in proper actions in the first minutes and hours when a patient arrives to the hospital. In order to deliver that course, we invited doctors from the very experienced doctors from the United States, surgeons like Dr. Blake, and we trained to instruct. We had two instructors for 4-year, 4-member team. Today, this one course was finished in hospital number 17, and now in total we have 250 doctors, physicians who undergo this course. This course, our objective is to cover all the doctors dealing with traumas. Similar courses are delivered on regular basis in Canada, in the United States. Our objective is to do the same in Ukraine. But it is not Blake alone who arrived to Ukraine. We have real American paramedicals. We have Oleksandr. I would like to invite one of you here to explain, to describe how you were trained, how you decided to become a paramedical, and how you became military paramedicals. And we all know that we have Ukrainian servicemen who stay at the front line, and we have military paramedicals, and we think that in civil life, those paramedicals, military paramedicals could become civil paramedicals and feed our membership of the pre-hospital staff.
My route to paramedicine. It started in the military, where I was trained as a first responder. After getting out of the military, I used this time and this experience to become educated and become a US paramedic. I'm not from America, but I recognize this as the highest global standard. The route there is not short. And I do understand that many people think of a paramedic as something that is a very short course, a certificate. It's not. It's a continuing education, and it's a lifestyle. I started off as a basic EMT. The first guy that arrives, he understands how to work the stretchers, how to drive the vehicles, how to safely control the traffic, and he understands how to assist the paramedic in every way. After that, I became an advanced EMT, learning more and more skills towards my towards my paramedic, sorry. Along this time is many, many hours of training and recertification. And with the education system being what it is in the US, every certification you do can build towards the final outcome, which is paramedicine. Myself, more than 1,500 hours in the US War Hospital in Iraq, working in the ER, gaining experience, gaining hours, courses around the world, in South Africa, working on the fast response cars, and of course going over to the US to do a college certification and more than 850 hours on the ambulances and 950 hours of didactics. Then you have to complete ongoing exams and a separate registry which is not attached to the certifying body. So 2 different registries, 2 different certifications, and every 2 years I must recertify in my profession. This makes, in my view, the system I'm within the most up to date. The medics on those streets, the most current. Did that sort of go the right way? Shall I escape?
Дякую. Ну, я хотіла, щоб ви почули, бо зараз ідуть такі
Thank you very much. I wished you to hear this because now quite often you can hear that a paramedical is a police officer who was trained within 8 hours and became a paramedical. Paramedicals, these are people with high education, with hundreds of hours of practice and internship, which have very special qualifications, delivery of assistance, basic paramedical technical staff is a specialist which could undergo several months training and get this qualification. It's quite easy to speak about training, etc. In the Ministry of Health, we can issue protocols, we can produce training curricula, we can prepare training courses, offer upgrading courses for emergency service, which is now existent, offer upgrading course for current paramedicals, Ukrainians. We have developed 4-week, 4-model course, paramedical course to current paramedicals in Ukraine. And this will be the similar course which is delivered in the United States. We can devote 6 weeks of training to our drivers in our emergency cars drivers. This will be like first responder courses which could be delivered to policemen and firemen in many cities of Ukraine, like in Poltava and Kremenchuk, Kharkiv, Odessa, Kyiv, and Lviv. In these cities of Ukraine, the policemen are trained this course, but all those courses are not recognized at the state level. We should implement this in Ukraine, and we will continue application and introduction of this system. Please understand that we do not wish to fire people. Quite opposite, we are bringing everybody on higher advanced level of professionalism. Objective is to provide services of higher quality to the Ukrainian population. We are ready to do all that depends on the ministry. We are ready to approve courses. We are ready to implement them. But we need support from the opposite side. We need response and interest from our medical workers. We need funding from local authorities, from regional authorities, and we will request financial assistance from donors. We can do institutional, formal things, but we need to get response from our medical staff. Please do not fear that we wish to fire people, but we try to improve the service delivery and to make it of higher quality when emergency service is delivered. We need to have the all full-fledged procedure in place from the first call to the surgery of trauma. We have 10 minutes for questions or comments from the audience. Dear participants, I will mention and signal every 5 minutes. Please raise your hands and ask questions on the topic. You have up to 2 minutes and then 3 minutes for remarks.
You have to up to 4 minutes. So the president of all Ukrainian emergency service and the main also, so he says about Rogov Anatoly Vladimirovich. Dear colleagues, you know, you said it right, and maybe everyone in this hall agree. And what we heard is not new. All these issues were raised during many years, and the documents were developed. And we worked on this for 25 years, and what we have at the moment, we have a law on emergency help, and this law we can criticize, but we can introduce changes. And it was developed taking into account European norms. We have 12 provisions of the Cabinet of Ministers that regulate the work of the service. We have about 10 orders of the Ministry of Health of Ukraine, and if it worked, that wouldn't be such problems we face at the moment, as the Deputy Minister stated. He said it correctly. And if we are speaking about training of police officers and firefighters, I support this. But in order to undergo training, there should be a proper order from the Minister of Internal Affairs. And also, there is proper provision of the Cabinet of Ministers, and there is the order of the ministry that adopted the training programs, and it doesn't work. In order that it is implemented, there should be political will. And I would ask Ulana, half a year ago, I prepared a letter for governors that they should pay more attention to emergency services and also introduction of dispatcher service. In Kiev, the system works, and Oleksandr said it correctly, that dispatchers, they can follow these situations, and they are called. In Kiev, there are about 6,000 calls, and 2,000 is registered, not because they do not go to all the sites, but we have 40 vacancies, and people, we have different modes of work of these dispatchers, and our colleagues come and ask what is the salary of the dispatcher, and then they propose the salary to work in other services, and that salary is much higher. And if you and I'm surprised by the position of the ministry, and that there should be automated system, and why each region develops its own task. In Kiev we have one task, in Kharkiv the task is different. Why there are so many different tasks for one service in the state? So we should work on the unification of this. There are technical conditions, but these technical requirements are not met. Also, the development of the network. Be brief, please. So, you know that there should be will of local government, and you know that we have terrible facilities, terrible conditions in our stations, in our even in capital the situation is bad, and in the regions it is even worse. So you are right when you are speaking about these issues, but it should be implemented in real life. So when you develop some documents, you should ask us, because we want to develop the system. So we should communicate, we should negotiate issues in order to improve the work of the service. Thank you. Good afternoon, Natalia Sanka, Chief Editor of Press Vita Edition. About the security for the doctors, we know the cases that some doctors were attacked in Dnipro city, and there were some other cases, and how these issues are regulated.
Usually the police are activated along with the EMS system, and that's a global activation, and they're to provide security for the paramedics. There's no organic members of security within an EMS group, and what I mean by that is the paramedics. There are very stringent federal laws that anybody involved in the obscuration or in intimidation or interferes in any way with a healthcare worker who is providing healthcare to a patient, the federal laws are strict, harsh, and impartial in that regard. That is a federal felony, and that is also echoed on the state and local level. So the penalties for interfering with EMS are severe. There are crazy people everywhere. And we can't always protect against those. I'm sorry to hear about doctors who were attacked, and we've had paramedics who've been attacked in the U.S. We have contingencies for that, but we probably can improve on that as well.
Захист лікарів.
So the protection of doctors, their security. So it is not only about emergency services, not about ambulances, but there is such a problem. And there are laws in the United States and in the European countries, because there are professional organizations, associations, that defend the rights of the doctors and medical workers and nurses. And in Ukraine, medical associations work differently. They do not work to protect the rights of doctors. They have their own goals. And we believe that self-governance of doctors will be a good step in this. That would be for protection of doctors, and medical community also should provide help in order to protect not only doctors but all medical workers. And that should be based on real needs. Everyone speaks about the rights of the patients, and they are recognized, but there are no rights for medical personnel that are recognized, and this should be discussed at the state level, and the balance should be reached, and balance should be established, and there should be parity in the protection of rights of patients and the protection of the rights of doctors. And we should speak about this at the state level, and we should do it by creating a special law or to create a concept how it should be implemented. And as you understand, the ministry, we do not deal with laws. We can write draft laws, we can submit it, but this is the level of Supreme Council. This is their responsibility. And we would start this dialogue, and I invite you to this dialogue. You can join us in this. We will welcome your participation. Thank you very much. Do you have other questions or comments? Please. Tell us, please. Do you have some procedures for the, if, for example, someone calls and this is not a medical issue, how would you respond? It's a good question. In a sense, So this is these issues are resolved at the level of the city, but in rural areas, these calls are a real problem. People call the ambulance because they do not have the possibility to get to the drugstore, and they just ask to bring medicines. And there is no doctor in the village, and the patients, they just call 103, and the number of these calls in rural area is big. And this is not the topic of today's discussion, but this first level of medical support, it should be reformed, and we want that these doctors of the first level, they should be there, and there should we would like to have less of such calls, and we hope that we will succeed in this. We will try to do everything possible in order to lessen the amount of this such calls. So there should be proper first aid, and we hope that call center there will be less of such calls due to the development of proper medical help in villages and rural areas.
If a paramedic is dispatched to a home and it's for something that's completely inappropriate, they are, of course, able to leave that person and not transport them to the hospital. One of the problems we have is we have manipulation of data or complaints by patients in order to achieve a transport. And there are ulterior motives, so it's not flawless. I can share with you that we've had people who have claimed a medical emergency only to get a transport to the hospital, at which time they jump out of the ambulance and flee on foot. So these things occur, but what's our opinion? Our opinion is that as a society, is that the needs of people who require emergency medical care supersedes the need for us to restrict people from performing crimes. If those people are caught and they're charged, then there are penalties for them, and that is based on state and local levels. But there are abuses within the system. We accept those abuses currently in order to achieve a greater good. And part of our development of emergency medicine and other things is eventually we hope that we can come to better resolutions of that. But your point is exactly well taken. Most of the time, though, the patients are transported to the hospital because there are no physicians on ambulances in the United States. So physician disposition is what is required in most cases, and there is a strong legal concern that if a paramedic provides a medical disposition, there are two things that they can be subject to. One is a criminal activity for practicing medicine without a license, and two would be civil litigation against themselves or their EMS system for if anything happens to a patient who is inappropriately dispositioned.
Чи є ще питання або уточнення, колеги?
Do you have other questions? This is the final question. Thank you very much. Maybe final remarks and we will end. So the laws can be perfect and provisions can be perfect, and there can be ideal orders of the ministry. When paramedics and doctors of emergency service, when they are at site with their patient, these papers, these documents, they are useless because life of the patient depends on the skills and knowledge and motivation and wish to help the person. And we will help paramedics and doctors to get proper education, and we will also try to provide adequate conditions of work for them. And we will fight for every kopeck to increase the salary of doctors, because we need to provide good level of quality. And you know that our doctors are just great and everything is good in this. They have good hearts. This is the third meeting, discussion how we are going to change medical sphere in Ukraine in order to improve it. And we want to have the system that is in Europe, in the United States, and Canada, because our patients, they fall ill and they die from the same diseases, and we should provide the best treatment, the best care, best conditions, and we should also create conditions for medical staff. And as you heard from our reports, that a lot depends on science, on training, because doctor and nurse, they save lives of patients. And you saw in this video that police officer, he can save life because he has proper skills and knowledge. And thus we should improve the system of medical care. And then I give the floor to Vira Nanivska. Thank you. Oleksandr Rybachuk is present here. He is the head of group of experts of the reanimation package of reforms. And we agreed about tomorrow's meeting, and there are two things that are provided by these consultations. First, the response got from this audience and response from other people, because many people read your reports and hear your presentations. And also, there will be a document, a final document on this, and also the response from the regions is important. The minister also today revealed the situation that there is established policy that is provided by the ministry and the government, and also there are provisions in the law and connected with decentralization and other processes, and we should implement it in the region. But the response that we heard is that people, they are concerned because old system is not in operation and new system is not implemented. And people, for them, it is difficult to implement new things. And at consultations in the regions, Ms. Minister said that you should do it. And we, of course, we will carry out the dialogue. And this is two things that I wanted to say, that we should get united in order to help the ministry to respond to requests. And this can be done by NGOs and experts in the framework of the project. And I congratulate you with this, and thank you. And I would like to greet you, because this is an unprecedented example when here in Ukraine, policy is elaborated, not just take decisions and then inform the results to the public. So about the communication in the regions. In the regions, this reform, they wait for this reform in the regions, and people, They want, but they do not know how. That's why they wait for the plan of the reforms, how it can be implemented into regions. And we, as the representatives of society, the representatives of NGOs, we are ready to help you with the proper communication of these issues. So this is the end of press conference. Till the next time, goodbye.